Hi, listeners.
Hello. Welcome to the Med Insights Unleashed podcast
With your hosts,
Z.
and John. So, Zara, here we are again today on another episode. We've been really blessed with the speakers that have come into Med Insights Unleashed. How are you feeling?
I actually want to say that I'm very grateful that you went to ASCO this year. So I wasn't able to attend, and I didn't mention that last time because ASCO always falls on, the last week of May straddling first week of June. And it's my husband's birthday. So for the past 13 years, I've always missed his birthday. So I said, okay, this year I'm going to skip ASCO so I can be there for his birthday. But John, grateful that you were able to attend ASCO because you had some fantastic meetings, met with some phenomenal healthcare providers, and as a result, able to generate some great episodes so far. And as such, today in our virtual studio, I'm going to let you introduce our speakers, and even the topic, very exciting and also very groundbreaking in terms of the research that we're now able to then share with the patients and the caregivers out there. So I'm excited, very excited.
So am I. And I'm very excited that we've got Dr. Ari Rosenberg back with us again to talk, to talk about his research with Dr. Maha Elsebaie, who is with us and presented really life-changing data at ASCO regarding HPV, circulating DNA, and HPV and head and neck cancer and moving forward on their latest research. But I just want to let the listeners know that Dr. Ari Rosenberg's previous 2 episodes, one was called Unveiling the Invisible Enemy in Head and Neck Cancer, and that particular episode introduces head and neck cancer and the newly diagnosed patients, and also talks about prevention in head and neck cancer. And his second episode is a deep dive into recurrent head and neck cancer with treatments and the prevention that can occur and assistance with patients with head and neck cancer. Topic that we're covering today is in the neoadjuvant setting, which I thought was amazing because we've talked about in the adjuvant setting, but now we're talking about the neoadjuvant setting, and we're talking about circulating HPV DNA dynamics and neoadjuvant chemo and the role of immunotherapy in this particular area with head and neck cancer. I'd like to let Dr. Ari Rosenberg and Dr. Maha Elsebaie introduce themselves. Congratulations to both of you and the team on the research that was done regarding this poster. Ari, over to you first.
Yeah, thanks, John. Thanks, Zara. Great to see you both again. And thanks for inviting us both back to your phenomenal podcast. So, Ari Rosenberg, thanks for that introduction. I am a head and neck cancer focused medical oncologist here at University of Chicago. And Dr. Elsebaie, do you want to introduce yourself as well?
Yes. So I am Maha. I'm one of the second-year fellows, clinical fellows at the University of Chicago as well. I am focusing my training in the second year on head and neck and thoracic oncology.
Yeah, we're so lucky to have incredible fellows like Maha joining us and working with us on some of this great work. And, just to answer your first question, John, really this is focused on optimizing treatment in patients with HPV-related head and neck cancer. I think, we spoke in one of the previous episodes about the different types of head and neck cancer. And one of the most predominant types of head and neck cancer that we see is HPV-related head and neck cancer, which is attributable to human papillomavirus and is rapidly increasing in incidence. And that's despite the fact that we do have vaccination available in the US and in other Western countries. It continues to rise in terms of incidence. And while this group, which tends to afflict oftentimes younger patients, although now older patients are also getting diagnosed with this particular type of head and neck cancer, the survival actually is quite good. And actually, the overall outcomes with treatment for HPV-related head and neck cancer are better than for the non-HPV, or what we call the HPV-negative counterparts. Yet despite that, the standard treatments are really quite toxic, both in the short term and in the long term. And, in terms of surgical treatments, or more commonly chemoradiation treatments, they can be quite difficult in terms of the side effects during treatment and some of the long-term toxicities that patients suffer from in terms of their quality of life long term. And so that's led to interest in seeing whether there could be a role for de-escalating treatment, or to try to reduce some of the short and long-term side effects. And this project is really focused on a new tool that's really emerging rapidly in the clinic, which is using a blood test to measure the HPV DNA from the tumor in blood. And that's really where Dr. Elsebaie's project has come into the forefront and highlighted in the context of this disease.
Thank you for
So Maha, would you like to talk about the circulating DNA and how you actually test the patients and then grade the patients associated with the disease?
Yeah, so historically, to test for HPV, you would have to go for the tissue, the actual cancer tissue to test it. But recently, there have been an interest in doing a non-invasive, just a blood test to see if we can detect the DNA, the cell-free DNA. So essentially, DNA from the cancer cell that escaped into the blood. And we can detect it using sequencing techniques and quantify it, qualify it, and, correlate it with outcomes. So the techniques have been, really evolving over the last decade or so. And that's what we used. We used one of the, techniques available right now called next generation sequencing to detect the DNA in the blood. So really that's what we used. And, like Ari said, the idea here is we're trying to see if we have a non-invasive predictive biomarker to correlate it with response to neoadjuvant therapy, to correlate it with, survival, patient outcomes, etc. So we call it liquid biopsy, and there has been a lot of interest recently in the promise of liquid biopsy, using it in early detection of cancer, using it to predict response, even to de-escalate therapy, for MRD testing, which is minimal residual disease in some patients who end up getting surgery, etc. You can use just a blood test to see if they have any residual disease in the blood. So, it's really promising, and such a non-invasive and cost-effective test that we're trying to see how we can best use it in our patient population.
Can you explain to our listeners what neoadjuvant therapy is, and then how this involves the actual treatment for patients with this particular disease?
Sure, I can talk a little bit, and then Eddie could probably take over. So essentially, the study that we did was on locally advanced patients, so patients who are kind of present midway, not really with a localized disease that can be taken completely out with surgery, and not metastatic disease, but something in between where they have a mass, but maybe some lymph nodes around it. So it's in an area that is defined, but still advanced a bit in its region. So these patients, end up, if they can't go to surgery, they get surgery. Otherwise, they go to chemoradiation, get chemotherapy and radiation therapy to take care of the disease. But to Ari's point, what we have been trying to do is to see if we can give them some kind of systemic therapy in the beginning, up front, and based on the response, select what to be done next in terms of chemoradiation or surgery.
When did you implement the utilization of the circulating tumor DNA tool? Was it done prior therapy and then after therapy? Maybe just walk us through that.
Yes, that's a good question. So essentially, what happened is these patients in the study they actually took clinical trials, and both of them, the patient had some form of systemic therapy up front. One of the cohorts only got chemotherapy, and then the other cohort got chemotherapy and immunotherapy, and we can talk about what immunotherapy means and the differences. And then the circulating tumor DNA was assessed at baseline. So the moment that patients get enrolled in the clinical trial, they get the blood test. And then they get assessed, during treatment, during the neoadjuvant therapy treatment, and then after completion of therapy as well.
So you had two cohorts in this particular study, 38 in one arm and 46 in another arm.
Yeah, so two
And
different studies, 38 and 46.
can you explain the immunotherapy that you used in conjunction with the chemotherapy and the number of cycles? Why 9? Why did you select 9 cycles?
Yeah, I can take that one,
Go
Maha.
ahead. Yeah.
But this was actually from a trial that we ran at the University of Chicago called the Optima 2 trial, which tested, like Maha spoke about, neoadjuvant chemotherapy with the addition of nivolumab, which is a PD-1 immune checkpoint inhibitor, and which we know improves survival for head and neck cancer patients with recurrent and or metastatic head and neck cancer in the more advanced cases. And so we hypothesized that by using nivolumab in the neoadjuvant setting with chemotherapy, that this could facilitate the immune system to be more active against the cancer cells, therefore driving more tumor shrinkage and therefore facilitating more de-escalated radiation for more patients to optimize both survival as well as functional and quality of life outcomes. And so the analysis that Maha did from that cohort was a subset of those patients in whom we had blood available both at baseline as well as after 2 or 3 cycles of neoadjuvant treatment. And so the 9 weeks that you referred to, John, are made up of 3 3-week cycles. And each cycle, patients receive carboplatin and paclitaxel, which are the basis of our prior pre-immunotherapy de-escalation trial called the Optima trial. And so the 3-week cycles involve three cycles of carboplatin, paclitaxel, and then nivolumab was the added drug in that particular trial.
Okay, I'm just going to paint the context picture very simply again. So essentially is patients were assessed, like you said, Maha, they were like the locally advanced, so kind of those middle kind of patients. You took their plasma, so their blood, so it was a couple of milliliters, I'm assuming, measured their circulating tumor DNA at baseline. Then patients received either the combination of chemo with immunotherapy or just a chemo alone. And the goal here is at the end of it, you're going to take certain intervals, you measure the circulating tumor DNA, and then the goal would be trying to de-escalate or see what post in terms of surgery or radiation could be de-escalated. Is that correct?
Yes, that's absolutely correct. Just to clarify one thing. So the ctDNA, circulating tumor DNA, currently is not being used to choose patients for de-escalation. That's kind of the hope for the future. But what we did was these patients, after they finished the neoadjuvant systemic therapy, they all got CAT scans again to see how much the tumor have shrunk down. And based on how much shrinkage in the tumor, we decided, if it's more than 50% shrinkage, then we can do, a form of radiation therapy that's not too intensive. But if the tumor have shrunk only by less than 50%, then they get the full dose of the radiotherapy. So that's how they were chosen for the de-escalation. But what we wanted to do is, okay, now we're using response to a new.
I saw that.
Yeah, exactly. To choose patients for de-escalation. How does circulating tumor DNA correlate with response?
Right.
And can also be used in the future also for to choose patients for de-escalation. I think that was my main questions for that project.
Can you just talk a bit about the staging that you use for the patients, how you assess the patient, whether high risk, low risk, just so people understand what sort of patient entered the study?
Ari can probably take that.
Yeah, so in HPV-related oropharyngeal cancer, we, at time of diagnosis, we do what's called staging, which is, John, what you're referring to, which is assessing in the case of these cancers, the size of the tumor, whether they involve any lymph nodes in the neck. If so, how many lymph nodes and how big are they to help determine the stage? And so these were patients eligible for these studies were what we call local regionally advanced disease. So patients had to have a T stage of either T3 or T4, so larger tumors, or they had to have more extensive lymph node involvement, either N2 or N3 disease, meaning that the lymph node has to be, meet certain size criteria. And actually, for our study, we actually exclude patients with very early stage cancers. So while these are local regionally advanced curative intent patients, these are patients with higher risk, local regionally advanced patients that include some of the higher risk patients for recurrence, patients with T4s, or the largest size tumors, patients who are heavy smokers, which we know is associated with a poorer risk for recurrence or a greater risk of recurrence with HPV-related head and neck cancer. So it was a very inclusive cohort of HPV positive head and neck cancer that we enrolled in the study. And then the risk stratification that you mentioned, John, we do, in addition to looking at response, meaning letting the patient's tumor tell us how responsive it is to our therapy to help select for de-escalation, we also look at the baseline risk and we combine those factors to personalize treatment. And so for our categorization, the high risk criteria are patients with T4 disease, so big tumors, N2 or N3 nodal disease, so either bilateral lymph node involvement, which is a high risk feature, or a large bulky lymph node over 6 centimeters, which is also a high risk feature, or patients who are heavy smokers, so with over 20 pack years, which is a way that we measure a history of smoking cumulatively for these patients. And so those high risk patients have different de-escalation than patients who have low risk disease. We give the maximally de-escalated treatment only to the low-risk patients who are deep responders. High-risk patients also get de-escalated, but not quite as much because, again, we're balancing the de-escalation to optimize the functional quality of life outcomes with what we want to maintain, which is the very good survival outcomes for these patients.
It was interesting when we looked at the patient that a lot of these patients, 60%, I believe, looking at the poster, had tongue cancer, right? It was around the tongue area. That's typical of a smoker.
Yeah, so these are mostly, it's a great question. For this study, for HPV-related head and neck cancer, it's mostly a part of the tongue called the base of tongue. The base of tongue, which is the very, very far back part of the tongue and what the part of the head and neck called the oral pharynx. So that's sort of in the very close to the area of the tonsils. And that is distinct from what we consider as the classic smoking related tongue cancer, which tends to be more anterior, meaning close to the front of the tongue. Those are the more classically associated tongue cancers. Those tend to not be associated with HPV. And so these are two distinct types of head and neck cancer. We have HPV related, which we mostly see arising from the base of tongue, from the oral pharynx further back, along with the tonsil. That's what was the focus of this particular project. And then we have separate from that, the more traditional smoking related tongue cancers, which tend to arise towards the front, are not related to HPV and are more commonly associated with smoking as the main driver of that.
Okay. That's an interesting definition subcategory. Thanks for that. I didn't even know that myself.
We always learn on these podcasts.
So, Maha, looking at the Kaplan-Meier curves, previously in oncology, I'm always into Kaplan-Meier curves, and we were talking about Kaplan-Meier curves yesterday. I was amazed at the Kaplan-Meier curves, both survival and progression-free survival. Can you explain the results that you achieved in this cohort of patients?
Yes, thank you. That's a good question. So I'll just take it a step back to talk about what we defined as the endpoint. So when we're doing any study, we correlate, like you said, Kaplan-Meier is essentially a visualization method to see how a certain endpoint correlates with patient survival. And for us, this endpoint was, if you remember, we measured the cell-free DNA at baseline and then after 2 to 3 cycles of neoadjuvant therapy. So what we did was we compared the two values we got for each patient, and we computed what we called cell-free DNA clearance, meaning more than 90% clearance of the cell-free DNA. So patients was able to clear almost all of the cell-free DNA that was available at baseline after 2 to 3 cycles of neoadjuvant therapy. So that was the endpoint, the cell-free DNA clearance. And then we used this endpoint to correlate it with response and survival, like you saw in the Kaplan-Meier curves. So what we saw really is that the cell-free DNA clearance, the patient's ability to clear their, this DNA in the blood really predicts tumor shrinkage a lot. So you can see there is one of the figures in the, in the left panel up front, that's a box plot, and it shows you how much shrinkage in the tumor there is after you clear most of your DNA. So it is a, predictive biomarker of response to therapy. And then when you look at the Kaplan-Meier, you can also see a big separation. You can see two lines, two big groups of patients. Some patients who cleared most of their ctDNA and they live longer, the top line. And then the bottom line are patients who were not able to clear their DNA as much. And unfortunately, they had recurrence of disease and then their overall outcomes were affected. So that is what we found is this clearance of cell-free DNA after neoadjuvant therapy truly correlates with patient outcomes and can really predict tumor shrinkage on the images as well.
I have 2 questions for that. Part 1. First is, were there certain characteristics of patients that had better circulating tumor DNA clearance? That's number 1. And number 2 is because you had, I understand it wasn't a randomized trials, but you had 2 arms. So was there one arm that performed better, the immunotherapy arm added on versus the chemotherapy arm? So those are my 2 questions.
So the first question, say it again one more time.
What were the characteristics of patients that showed a better improvement in clearance of circulating tumor DNA?
Yeah, that's a good question. So what we did is we correlated the cell-free DNA clearance with the baseline patient characteristics, things like age, gender, race, and some other things like the T stage, like how big the tumor was when they started the trial, etc. And what we found was patients who have smaller tumors at the beginning, so T3, for example, versus T4, were able to clear their tumors much better, their cell-free DNA much better than patients who presented with larger tumors at baseline. And then to your next question, which is quite an interesting point. So 38 of these patients got chemotherapy, immunotherapy, and 46 got chemotherapy. And the degree of clearance of the ctDNA was actually higher in patients who got immunotherapy. Now, we're still trying to explain this finding and whether or not immunotherapy is adding something to chemotherapy in terms of clearing the DNA. And I think Ari can comment on this.
Yeah, I think, Maha, that's exactly right. And, the suggestion, we know from now a number of studies, including our study, that, clearing rapidly the circulating tumor HPV DNA from plasma is a good thing. It's a good thing for patients. It means that the tumor is more responsive and that those patients from Maha's data are likely to do better. And so the trend towards higher clearance with the addition of immunotherapy in this parallel cohort, to me, suggests that the immunotherapy is driving an anti-tumor immune response on top of the chemotherapy that drives greater clearance of circulating tumor HPV DNA. And I think this is where we're certainly going to be looking at this in more detail and with larger numbers of patients to better understand this relationship. But we're now seeing in the head and neck cancer field more accumulating evidence about the importance and the potential role for immunotherapy in the neoadjuvant setting. Last month at ASCO, and actually prior to that at AACR, we saw data from the Keynote 689 study, which was the first randomized phase 3 study to test neoadjuvant immunotherapy in resectable head and neck cancer patients. So these are patients that would normally go straight to surgery. And that actually found that the addition of neoadjuvant immunotherapy for patients that had a positive PD-L1 biomarker seemed to improve what's called the event-free survival. So seemed to lead to better outcomes in these patients. highlighting that immunotherapy, when given in the neoadjuvant setting, again, before surgery or before chemoradiation, may be beneficial. And I think Maha's finding of the higher ctDNA, circulating tumor DNA clearance in the immunotherapy patients also dovetails with that finding as well.
It poses a question to me because neoadjuvant therapy is usually used for debulking, right? You actually give the chemotherapy, you do the surgery looking for PCR and curative intent. Does your study, this is the question I wanted to ask at the poster, but now I can ask it in real life. Does this poster give the inclination that you may not need the surgery? Would the response from looking at the Kaplan-Meier curves, from looking at those patients that got to greater than 95% or 50% response rate, and we're in the higher 95 percentile group, which is basically a flat, both PFS and overall survival is quite astounding, suggests that surgery is not needed?
Yeah, it's a great question. And the short answer, John, is that we don't yet know. And I think, future studies will hopefully be able to clarify that point. Eliminating surgery and radiation in the era of immunotherapy is, I think, a question that many of us have been interested in asking. And at the same time, we have been stepwise in our approach in that direction because we want to make sure ultimately that we're not compromising the cure for patients with a highly curable cancer. So our approach has been, rather than eliminating surgery or chemoradiation altogether in selected patients, has been more of a stepwise fashion of, well, we're going to de-escalate to this level. Yes, the outcomes still look good. In the next study, we're going to de-escalate to this level, right? So learning as we go along what the right level is, in that sense. I will say that there have been some cautions that circulating tumor DNA is certainly not perfect. For example, there was a study that was presented in patients who underwent upfront surgery with HPV-related head and neck cancer, and those that were negative for circulating tumor HPV DNA after surgery were then just watched with no adjuvant treatment at all, and a substantial proportion of those patients ultimately recurred, suggesting that the circulating tumor HPV DNA is not perfect and that having a negative result, particularly with the current standards at a single time point, is probably not adequate to give us confidence that there's a 0% chance of recurrence. And so that stepwise approach, I think, is quite important. In the study that Maha presented, we, the clearance are looking at very early dynamics, meaning after just a couple cycles of chemotherapy or chemoimmunotherapy, those patients still go on to receive chemoradiation or surgery and are, then followed subsequently. And so it's being used as a selection criteria rather than as a patient clears and we're not going to give them any further treatment. So it's a great question. I think we would love to have that where we could do a blood test and say, look, this is negative and there's 0 chance of recurrence. As much as I would love for that to be the case, I think the data doesn't quite pan out that way yet. And we need to continue to develop better assays, better tests that can be more sensitive for minimal residual disease so that we can have more and more confidence in a negative blood test.
So what happens to these 84 patients now that you're following?
Yeah, I mean, the patients across both of these trials did incredibly well. The progression-free survival, overall survival across both studies was well above 90%. Yeah. And that's with de-escalating the vast majority of these patients. The vast majority of these patients received less than 70 gray of radiation, with some patients receiving surgery and no radiation whatsoever. So the promising outcomes are quite there. This has led to a number of follow-up studies, including one that will be opening in the coming months, that will be building on the results. But it's certainly we think, quite promising and warrants further investigation in how much can we select and de-escalate these patients to, again, optimize survival while minimizing short and long-term toxicities for patients.
So on that, I think the next question for me would be, I understand that, well, okay, my simple question would be, is this practice changing? But I get from you that this is still early, early time, right? So to be determined because we need to collect more data. But yet it's so compelling because you are trying to eliminate that toxicity that patients would be exposed to. So how do you balance that out?
Yeah, it's a great question. And, the HPV DNA blood tests have come into our clinic quite quickly.
Mhm.
And many of us are using commercial blood-based assays, mostly in the surveillance setting. So after treatment, doing a blood test serially over time to help surveil for recurrent disease. And I think, there are commercially available assays that are being used already in the clinic in that particular setting. The setting that our study speaks to, and where we actually saw also data from the Dana-Farber group, is what about using the ctDNA during treatment to select patients for de-escalation based on who clears and who doesn't clear.
Yeah.
We saw the first study that really tried to do this actually presented at ASCO this year. This was Glenn Hanna's REACT study. Glenn Hanna and John Schoenfeld are collaborators and colleagues from Dana-Farber who actually looked at the ctDNA clearance during chemoradiation. And those patients that cleared during chemoradiation received a slight reduction in the radiation from 70 gray to 60 gray. And those results also looked quite promising. And we look forward to seeing that data in manuscript form as well. But certainly, I think, does highlight that these are powerful tests that, when employed in the correct treatment setting, can help us with potentially guiding treatment to reduce toxicities for patients while optimizing survival and quality of life. But there are lots of challenging and more work that needs to be done in this way. And his group's doing that, our group's doing that, to be able to show that we can use these assays in that particular setting.
The listeners can't see these curves, but basically the cohorts that are responding are flat. Maha, when I saw it, I was just amazed. When you see the response that you achieved with the immunotherapy group versus the standard cohort group, it's quite stunning. It's just like you want to get out there and change the world, but obviously you've got to temper, as Ari said, you've got to temper the enthusiasm and get more data.
I had another question from Ari, your comment. So I understand, do you think it would be valuable to, as you're able to demonstrate the time points you're collecting the data, the CT tumor DNA clearance, could it also be an opportunity to then, I guess, alter or intervene with the patient, their immunotherapy strategy, i.e., you don't have to give them all of the cycles, but perhaps after the measurement of, like the 3 cycles or the 3 weeks, you assess the tumor DNA clearance and then assess, is it necessary to continue the rest of the cycles of the immunotherapy, or maybe de-escalate that component as well? Any thoughts around that?
Yeah, Zara, you're going to come join our group and develop a trial with us?
Sure.
Doing good ideas there.
No, it's great. I mean, I think, right. I mean, once based on Maha's data, you can see that the patients that rapidly clear their circulating tumor HPV DNA are going to do well. And the way that we use that to then optimize subsequent treatment, right? To your point, there's lots of ways that we can do it, whether it means giving less neoadjuvant therapy, whether it means, reducing radiation. I think our group has been particularly interested in reducing radiation because the radiation component is that, the dose of radiation and the volume of radiation is what largely drives the long-term late toxicities. I think that's therefore been, the main focus or interest from our group. And we've shown from our prior de-escalation trials that patients that can receive less radiation have better functional outcomes. We actually had one of our other University of Chicago fellows presented the functional outcomes with de-escalated radiation with what we call response adaptive de-escalation, which is what we title this strategy. And indeed, patients that received less radiation had better functional outcomes, better quality of life outcomes, lower feeding tube rates, and all those things that you'd expect from someone that has lower, that gets lower doses and volumes of radiation. So that's been the focus. But you're absolutely right that, there's a lot of different ways that you could take that potential biomarker,
Right.
Forward in terms of optimizing treatment outcomes.
I mean, that's been the big discussion in the advanced areas, how many cycles you have to give as well as in the adjuvant, right?
Yeah. And just to highlight that, Zara, right, the other way you can use circulating tumor HPV DNA is the flip side, is escalating treatment, right? And in patients that have completed chemoradiation with HPV-related head and neck cancer and have a positive HPV-related circulating tumor blood test, we know are at very high risk of developing recurrence down the road.
Right.
And we and others have been very interested in that space as well can you actually escalate treatment, right? Can you give to your point, can you change to a different intervention might be more efficacious based on the circulating tumor HPV DNA blood test that portends a worse prognosis, right? So the flip side of de-escalation. And I think that's also an area there that more work is needed.
Could you pulse like we do in colorectal cancer in maintenance therapy? You can just pulse with the drug. You're watching the DNA, and if it rises, you hit them, wait for it to go down. When it drops, you wait, watch and wait again. Then as it rises, you hit. Is that a possibility?
So we do have an ongoing trial that's asking exactly that question, John. You can join our group too and design some stuff with us as well.
We John in the future.
Yeah.
Now he knows.
It's a trial in the recurrent and metastatic setting, so not in the de-escalation setting. This is in the recurrent metastatic setting, but where we're using the circulating tumor DNA to pulse chemotherapy on top of the immunotherapy backbone. In other words, if the tumor DNA goes up, we pulse the chemo to drive down the circulating tumor DNA. And when it goes down, we then de-escalate the chemo component. That's called the Synergy trial, and it is almost finishing accrual at this point. But it's a great question, and I think we'll look at the results of that and see if we can learn anything about the way that we can use circulating tumor DNA in the more advanced setting as well, in the recurrent and metastatic setting, to optimize treatment. Again, optimizing and improving survival while minimizing toxicities is the ultimate goal for these recurrent and metastatic head and neck cancer patients as well.
One thing both Ari and Maha wanted to say is this study really highlights another piece, and that is the value of circulating tumor DNA. It's so non-invasive. It's, blood plasma can be easily accessed. It doesn't have to put the patient through the whole tissue biopsy component, which is already stressful. And patients always ask, hey, doc, I'm on immunotherapy or I'm on chemotherapy. Is it working? Yeah, because they want to know, is it working? So here is a tool that one has access to that is non-invasive. You can actually measure that through the clearance that whether your tumors are responding. So applicability, practicality, how can you comment on that with regards to this circulating tumor DNA tool?
I think honestly in clinic, we have seen patients, they do follow up the results, and it's a lot easier for them to look at the graph and see the number go down rather than to look at the report from the CAT scan and be like, what's going on there?
Yeah, exactly.
So patients have been excited by the results, and they know, we've been, every time I go see them, I would print the report and take it and show it to them. And they get excited about how the graphs and the numbers of the DNA are coming down nicely. So to your point, it is reassuring for them and also for us to see these early responses, because we don't have to wait, like in the trial, for example, we don't have to wait until we finish the neoadjuvant therapy after 3 cycles to get the CAT scan and then wait for the of the CAT scan. You can just do a blood test after cycle 1 or cycle 2 and see the number go down, and that's good for us. That's reassuring for us and for the patient, and it answers some of their questions as well. So it is applicable. It's quite applicable. To Ari's point, it's a matter of trust in these tests, and there is a lot of heterogeneity out there in terms of what assays are being used in different trials. That's another point. It's a big challenge for things like the FDA, for example, is, okay, we have these tons of DNA assays out there that needs to be validated on prospective clinical trials as well. So one of our focuses here at the University of Chicago have been to design biomarker prospective clinical trials with the goal of testing some of these assays in a prospective manner. So in a clinical trial to validate some of them for the future. And unless we do that, unless we and other people do it, some of these tests, no matter how good they are, they might not ever make it to the guidelines itself.
And this is blood, right? So you're putting a needle in and sucking out blood, right?
Correct.
And for us needle phobic people, I'm needle phobic, but the simple reason is that I've got small veins and they're very hard to find. So I always say, if you can't get it in 2, you're not going to do it at all. Is there a way of getting the DNA from the swab to actually test, or is that just not test available? Do you understand the question?
Yeah, no, I think saliva-based tests
Yes.
is also under investigation. Some folks from our group, Dr. Izumchenko and Dr. Agarwal, have actually developed an assay to try and see if they can screen for oral cavity cancers, for example, using saliva-based tests. So I think that's also, obviously, for head and neck cancer, of great interest. It does seem, in terms of tracking with disease status, that the blood-based tests have, been the most convincing and certainly the most advanced in the development sense. There's other bodily fluids as well. So, the group from University of Michigan is looking quite a bit at urine-based tests as well. So, right, we have lots of ways we can pull biomarkers, and we should be looking at all of them. But I would say the most advanced, at least in the head and neck cancer space, has been blood-based tests. And, maybe we can give you, we can have one of our master phlebotomists help with withdrawing your blood, or we can always use an ultrasound to make sure that, John, we don't want to put you through too much discomfort.
Thank you, Ari. Maha, in 3 or 4 bullet points, how would you summarize your research and what it means to patients out there that are listening to this podcast?
I think what I'm going to say is toxicity from head and neck cancer treatment is real, and the actual numbers can be very shocking. 100% of these patients can get inflammation of their oral mucosa. 40% of them, it's very severe. 40 or 50% of patients have late toxicities where they need G tubes, intratube feeds, tracheostomy, so ear tubes, etc. So these toxicities have been real in patients and major focus for our patients, and that drives our de-escalation efforts. And to choose patients for de-escalation is a big question. Using neoadjuvant therapy has been really promising. To your point, John, shrinking the tumor, right, and make it more amenable to radiotherapy and surgery, etc. And then to select patients for these less intensive local regional treatments like radiotherapy and surgery, we are using predictive biomarkers. One of them is the ctDNA, and I think it has a real promise as long as we keep studying it in clinical trial settings to validate some of the assays that exist out there.
And I think your mentor is very proud.
Yes.
I'm very
I can
fortunate.
see I can see it in his face.
That for sure. That for sure.
So you're really good. So any other comments at all before we close out? It's been a brilliant meeting.
Yes. Yeah. Thank you.
It's
Very, very
been-
interesting. And John, thank you. This has been really valuable. Again, learned a lot.
I saw the poster.
ASCO wasn't like a birthday celebration, of course, but we do
I
what we
bet you
can.
had much more fun than I.
Ari, I looked around for you at ASCO. I went to a lot of head and neck discussions, and I owe you a cup of coffee from our last meeting, and I thought I could repay it, but I just didn't get there.
Sounds good. Next time, next ASCO or sooner.
There we go.
Okay. Thanks.
All right.
Thank you,
All
Bart.
right. Well, thank you both. And again, Maha, congratulations
Thank you so
on a
much.
wonderful poster. It's got such an impact on patients, the 84 that you've already treated, and also the potential for the future to change the future outcome. Amazing. Congrats on that.
Yeah. Great job.
Thanks so
Thank you,
much.
everyone. Thanks. Nice
Bye.
seeing you.
Bye.
Bye.
Bye. MedInsights Unleashed disclaimers. This podcast is for general information purposes only and should not be considered healthcare advice in any way. The podcast is not intended to replace professional medical advice. The use of the information and material linked to the podcast is at the user's own risk. MedInsights Unleashed is not responsible for any losses, damages, or liabilities that may arise from the use of the podcast. Importantly, please consult your healthcare provider for individualized guidance and treatment. Thank you, and we look forward to you being with us on the next MedInsights Unleashed podcast.